Thank you all for joining us on this third part of the Automated Guidelines for Healthcare Reimbursement series. Today is our final session for this series, and the two first parts are already up on our website in the webinar section, so you may watch them or rewatch these sessions on demand. Today we will talk about documentation of medical necessity for CMS home services, CMS being the Center for Medicare and Medicaid Services. This session is also recorded and will be added to our website as soon as possible. Just check your inbox within the next 24 hours. We will be able to share the link very quickly. Once again, I'm joined by Dr. John Spiberly, Trisitech CMIO, and Denis Gagné, our CEO. As usual, you can ask them your questions as we will have time to answer them in the last 10 minutes. Don't hesitate to use the GoToWebinar questions tool to send them over at any time during the presentation. I will collect them along the way so we can address them at the end. So Denis, you can just go ahead and start the session.
Thank you very much, Jonathan. Good day, everybody. This is our third and final webinar on our series on healthcare reimbursement. And the goal with this series of webinar is really to introduce you quickly to the notion of automatable guidelines. So automatable guidelines are basically single knowledge artifacts that are both human readable and machine automatable. So our objective in using these automatable guidelines is to help with the guideline portion, which is to try to disintegrate traditional narrative guidelines that are often prone to different interpretation. And the automation portion is about providing the clinical knowledge at the right point during the flow of care. So together, these two objectives are met by this approach that we're promoting here. So in doing so, we're marrying the standards, a series of open international standards from two standard bodies, namely the Object Management Group and HL7 International. And all these standards are open and interchangeable and provide the interoperability to move across various environment and deployment. From the Object Management Group, we're basing the work that we're promoting here on the BPM Plus Health community. The BPM Plus community is a community of practice that brings together different institutions, professional societies, vendors, and users, whether be it provider, payers, or even patients, contributing to making a strong and robust standard and open international standards for interoperability around healthcare, and in particular in this context of these webinars, we're focusing on reimbursement. So from the Object Management Group, the main standard that we're promoting here is the use of BPMN, which is a business process model annotation. And very quickly, the general understanding of BPMN is whenever you see a circle, we're talking about an event. Whenever you see a rounded rectangle, we're talking about an activity, and the diamond shape are there to basically provide some behavior of routing. We call them gateways. And so BPMN is very simple for us to read. Just about everybody can read a BPMN diagram, as it is a flowcharting type of notion that everybody has used. So when this starts, we do a first activity that is a service activity. So we have markers that indicate the kind of activity. When this activity is completed, we move to another activity. Here we're doing a PMML predictive model. So this is some machine learning model that's doing some prediction. Then we're moving into another activity. Here is a CQL, which is the clinical quality language from HL7. So we're doing a medical measure here. Then when this completes, we go into a decision task and using another standard called DMN to capture the logic of the decision. Then based on some results, we will branch either to the upward part here to a case task where we're managing a case using the CMMN standard, another standard from the OMG for case management. And then when we meet this intermediate event here, so the circle is an event, we're waiting for a message from an external party before we carry on. On the lower end, we would go into a sub-process. A sub-process is basically a much more detailed version of this, so we can view it in an abstracted version with the plus showing, or expand this sub-process to see the detail. And then we have the notion of data objects, which are information and knowledge that is provided to these tasks. So that gives you a very quick overview of the core of what we're basing these webinars on, the core technology and standard that we're basing these webinars. So in our previous two webinars, we discussed pre-authorization, which basically involves the determination of medical necessity prior to the service being provided. So the first two webinars, the first one was on surgical pre-authorization, more particularly total knee arthroplasty, and the second one was on off-label drug usage. And in both these cases, we showed how we could enable and facilitate and improve the pre-authorization process. Today, we'll discuss the determination of medical necessity after the fact. So here in this case, the service is already being provided, and we want to make sure that medical necessity is met. And usually this is done through some use of some form of audits. And particularly today, we're going to focus on home oxygen services. The benefit of automating these healthcare reimbursement, whether it's prior or post-service being provided, is many. And you can imagine some yourself, but for patients, for example, we make sure that the necessary care is provided within a minimum delay, that there's reduced stress and anxiety because everything is clearly defined and scaffolded. And there's no incurred financial surprises. So it's not like suddenly you find out that you're not going to be reimbursed for that service. From the provider point of view, you have real-time education, clear understanding of the acceptance criteria, and lower administrative burden. And naturally, for the payer, which has been the focus of this series of webinars, we provide effectiveness by having the complete and correct information right at submission, efficiency by increasing the decision throughput, and with all these benefits, the capability of reallocating the resources in the organization. So without further ado, we're going to move on to our topic of today, which is home oxygen therapy, and I'm going to pass it to John to lead us through that portion of the presentation.
Thank you, Danny. So today we're going to be talking about home oxygen therapy, one of the several services that CMS provides to people at home. And the magnitude of the issue is much larger than many people realize, with up to 1 million people receiving the benefit, and the cost, at least at this time, running about $2 billion. Next, please. The guidance from CMS is fairly straightforward. It's a 2-pager that outlines the various requirements, rules that are stipulated for a person to conform to the requirements. Next slide, please. As shown in the previous webinars, this knowledge can be modeled in a BPMN model, as shown here, where the whole model is onto your left, and then a higher, closer view is to your right. And basically, the rules consist of various tasks and processes, decisions that need to be made, such as are there contraindications? Does the person meet the clinical definition for the service? And then some objective data, in this case, laboratory values, to help support the necessity. One thing about home oxygen is that this involves a functional classification where hypoxemia, which is why the oxygen is being given, is the endpoint of several disease processes. So that adds a little complexity to the model. Next slide, please. But when you have a system as large as this, there's this many people involved, problems arise. And the issue is, can process automation help reduce these issues for the various participants? The participants are the providers who can have problems, patients can have problems, and then CMS as the payer can experience problems all related to relatively complex system. Next slide, please. When we look at how CMS does confirmation of medical necessity, the assumption is that when the service is given that medical necessity is present. To confirm it, what it does is conducts audits, and the audits are performed by contractors, and often these reviews are done weeks, months, or longer after the service was provided. And this is a potential problem for providers. Once the auditor comes in, they have a group of charts that they reviewed, not the entire group, but a subset. And then based upon the findings that they have on that subset, they extrapolate their findings to the whole group. So there are two potential pitfalls that can affect providers, the unwary provider. One is that if a problem has been introduced into the operations of a practice, it might be weeks or months before they realize that there is a problem. And so they can be trapped into unrecognized error. The other is that the assumption of the chart review is that it's a representative sampling of the charts. And if there's any bias in the choice of charts, the extrapolation can either raise or lower what the true reality is. Next slide, please. And many of the problems that people find during documentation are due to human error. There's poor documentation or no documentation, incorrect coding, missing or unsigned orders, and then incorrect or missing dates of service or dates that don't correlate with other findings in the chart. And so next slide, please. Now, the consequences of these errors are much greater than many people appreciate at the time of occurrence. If the auditors come in and find problems, they can demand that the money be repaid to the CMS. The other is that if there is a pattern of behavior that is observed, the government can charge the provider as doing this intentionally, which becomes a criminal offense, which has all sorts of ramifications. Because the data is delayed, because there can be omissions just to human performance, the only way to protect yourself against this if you're a practice is by having very tight operational controls and to include some type of self-audit to detect problems before they can be found, all of which costs money and is inefficient in the practice. Next slide, please. Well, when we look at the previous diagram for the model, each of the tasks has layers of information that can be applied to the model. This is one step which asks about was the person hypoxemic during sleep. You can load each task with all the information you need there and then to answer a question, deal with a question without the need to manually look things up or pull down a book. Up at the left under the little blue square, we have the idea that the semantics of a process can be described. Special rules or exemptions can be included within the notes. All the codes that are needed, both SNOMED, ICD-10, or any others that you want, can be provided so that these are available to be exported to the transmission when they are ready. Date and time are captured, person performing it are captured. So this is really self-documenting. And because nothing gets done until the rule is complete, there are no omissions at time of completion. And because everything is done in a standard way, the chance of having unexpected errors is extremely low. Next slide, please. So that dealt with how providers can be affected by manual systems. Patients can also be affected because they're really kind of dependent on everyone else doing things right. They often are elderly. They may have multiple comorbid conditions. And if therapy is interrupted for any reason, they are at risk for deterioration. They're also vulnerable both physically, mentally, and economically. Next slide, please. When we look at errors in provision of a necessary service, if for some reason the physician or the home health care provider drops the ball, so to speak, you make an unnecessary interruption of service, which means that the person doesn't get their oxygen in this case, or there may be need for an emergency backup supply to be provided, which might cost the patient money. And then the patient may benefit from other services, which may not be introduced as soon as possible for the best care of the patient. Next slide, please. So when you get into oxygen, one of the features that you have after the initial certification is that you have to be recertified. And this is a relatively simplistic model to show how some of the rules affect the patient. A lot of the rules, once a person has been certified, include timing of events, so that the certain things are done according to a particular schedule, and the schedules impact other schedules, which all can snowball down the line. When we start off to the left, the first mark shows that the process is starting, which is a person who's on home oxygen. And then there's a schedule has to be determined as to when recertification occurs. And so that takes data, comes in, various tests might be done, and various diagnoses might need to be determined. And the rationale is that if a person has severe hypoxemia and it's permanent, it's unlikely to revert on therapy, the recertification is done every 12 months. If the person has mild hypoxemia and a disease that might be reversible, recertification takes place at 3 months. Now, to do the recertification at 3 months, you have to evaluate the person before then. So in this case, we've modeled it, say, 2 months before you get a reminder that Mr. Jones needs to be recertified. So that goes off, and you have to collect the testing data. You also have to maybe do a physical exam or collect other data, which all takes time. That gives you about a month to complete the model so that you can recertify on time so that there's no interruption of services. So when this is done, the chance of having an omission is much less than in a manual system. And if usually they're built properly, you have plenty of alert so that everything is done efficiently. And so we're going through one more example showing what happens for a person with more chronic disease, and that again, the recertification goes off to the endpoint. And in practice, if in a full system, this would loop back upon a cycle to continue as long as possible. In one of the cases where it was minor disease, if the person no longer meets criteria, they then would no longer be eligible for the service. Okay, and that brings us to the CMS portion.
So naturally, CMS is always seeking to get better information on the quality of care. As we mentioned, in this particular context, the information is a posteriori. It's after the service being provided through some kind of audit that is carried out. Now, in parallel or conjunctly with this, CMS is always looking to get better information so that they can assert the quality of the care being provided. There are different goals associated with looking for quality of care. Some are listed here based on the most recent objectives from CMS, but basically it's to promote the effective prevention and treatment of chronic disease and other aspect and administrative elements. Anything else, John?
Well, I think one key point is that the information that CMS gets is often dated. Often the feedback you get is from a year before, 2 years before, 3 years before. It's not real time. And if you really want to make impacts on systems, it has to be real time. If you're a provider and you're not getting real-time feedback, you blow things off. And so things are not as efficient as they could be, and that's really what you need if you really want to take the quality of care to the next level. Thanks, Dane.
Thank you, John. So this is where we start introducing another standard, this one provided by HL7 called the clinical quality language. And with the clinical quality language, we can express some clinical measures that we want to take as part of the automation. And so the clinical quality language is a little bit more of a literal type of language that is quite easy to read to understand what's going on. And then we can introduce this measure right into the process. So for example, we would do the recertification that we just demoed into the animation there. And once the recertification is complete, we can then run the quality of measure and provide a quality of care report. So hopefully with this very quick introduction, our aim here is not to really do an in-depth type of diving here. We just wanted to create some awareness and generate some question. We believe that this shows clearly the benefits of using process automation in this context, where you get more complete and accurate documentation in near time or real near time. Fewer errors impacting the patient care, which is very important. Oftentimes, as John mentioned, with all the rescheduling, things get lost, files stay on a desk somewhere. By automating all this process, you make sure that all the meetings and all the visits are scheduled and managed and orchestrated in a timely and efficient manners. There's also the improved insight into the quality of care by tying in the quality of care right into the automation. It allows us to get the data right as things are happening, rather than being data that is historical in some shape or form. John, anything else you want to add to the conclusion before we move to questions?
No, I think that completes it. Thank you.
Okay, thank you. So
Thank you.
Jonathan, back to you for the questions.
Yes, thank you. And to everybody in this session, it's not too late to send your questions. I just received a few, so sometimes people wait until the end to see if their question will be answered by then. So that we still have some time, but I have a few. Well, first one here is more a comment than anything else. Hassan saying that anything that can shorten the turnaround time for prior authorization makes providers happier too. So yeah, goes in the same vein. So we have a first question that came in really early. So I'll just go ahead and read it. So the person is asking, so the process will make sure that all the steps are respected so that it is possible to prove that the assessment was done correctly. So I guess that was more of a summarizing thought here.
Yeah, you're quite right, and that's the whole idea. And the benefit of the approach here is that, as you saw with the visual rendering, you can easily read what's going on, and it's very simple for human to understand and follow those rules and follow this flow. More importantly, at the time where we're preparing these automated guidelines, the subject matter expert can jump in, clearly understanding and point at where things should be done different or where things have to have more flexibility. So it provides us not only with the benefits of the automation, but also the benefits that we have a single artifact that is available for the subject matter expert to ensure that it really reflects the evidence-based guidelines that we can explain to the patient using even the animation we just showed, and how things will happen, and then we can use it to the actual automation. So there's a lot of benefit of using this approach.
And if you build in provider steps into the models, you can then personalize care to the specific patient, because not all the models include all all contingencies. And so there are ways of building flexibility.
Thank you. So we have another question here on something a little bit more specific. So you talked about real-time feedback to the provider. So we have someone here asking if you can expand what you mean by this real-time feedback. How would that be done?
Okay, when I say real-time, I'm talking relative real-time because that's in comparison to weeks or months after the effect. To do it real time, in theory, you could do it, but it'd be relatively expensive. We're talking about probably a few days would be probably more realistic that feedback would come back. If you wanted to build it in, you probably could, but that would be so enormously complex. I doubt everyone would really want to do that. But a few days is better than what we currently have.
Yeah, and the real time relates to the fact that each activity are orchestrated by the system and ensures that it's happening at the right time that it should happen. So it orchestrates the steps that are following. So and I'm not sure if we were referring to the quality measures that were done in real time, but all the data is collected by the system and then this can be reported either one at a time or in batch mode, depending on the organization and the desire.
Perfect. Thank you very much. So for now, we don't have any further questions. For people in the attendance, if you have any question, you can simply reply to the confirmation email. It will go straight to my inbox, and I can arrange to make sure that we answer your questions. Otherwise, I'll just thank you very much, Denis and John, for your time. It was a great series. I think we covered a lot of ground here. So any final comment, final thought here?
Yeah, no, thank you very much for attending and asking the question. In fact, I would invite anybody attending any of the webinars, if you have suggestion of topics you'd like us to tackle and do a webinar on that topic, please send them to us either at the support at Trizatec or directly through the comments in the webinar connection that you have, and we'll gladly make a webinar on that topic. Thank
Yep,
you very much for attending.
Thank you.
that's for sure. And also I will send you, as I was saying, the recording. So you will receive a link, an email from me. So if any of those topics or any questions that are still to be answered, you can simply reply, and we'll arrange things for you guys. Thank you very much. Bye-bye.
Thank you.
Thank you, Jonathan. Thank you
Bye-bye.
all.